Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
My name is Ajay Nuka. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
This is a 65-year-old male with newly diagnosed IgG-kappa multiple myeloma, RISS stage 2. And the main question we're going to get at is, what would the treatment approach be for this newly diagnosed patient with high-risk features? And the specific high-risk features we're going to get to in a moment. So this is a patient who presented with back pain, which, as we learned from Dr. Forsberg, is fairly typical. The performance status was 1. This patient has a history of asthma and psoriasis, no relevant social or family history. With respect to the oncology history, in March of 2021, a pelvic CT scan showed lesions at L3 and L4. And this patient was referred to the spine team for a radiofrequency ablation and a kyphoplasty at L4. Ultimately, an FNA of that L4 vertebral body did show sheets of kappa-restricted CD56 positive plasma cells. So maybe, Dr. Nuka, can you tell us, when do you recommend the use of kyphoplasty?
So as Dr. Forsberg earlier alluded to, almost 3/4 of the patients present with some kind of a bony disease. So it affects the treatment's stratification, or the initial stabilization happens with the bony issues that we're dealing with. So the first question, there are lots of patients that probably may be completely asymptomatic, in which case my goal would be to start them on the treatment systemic treatment as quickly as possible. In a patient where I'm afraid about getting the pain under control with an acute fracture, those are the patients who need stabilization, because the pain can be excruciating even before the systemic treatment starts to help. Those are the patients I pick up the phone and call our colleagues to help us with getting an immediate stabilization for pain control.
Great, thank you. And Dr. Schuster, I know we don't have imaging specifically for this case, but we are told about these lesions in L3 and L4. And when you're reporting on a case such as this, a patient with pain, bone pain, and then these lesions, are you able to, with your experience, to delve deeper into a potential differential diagnosis, or do you think that that's not appropriate outside of the, just waiting for path results?
So no, I think it's very appropriate to give a differential diagnosis. Of course, when we see these lytic lesions in 2 locations, you're going to want to know where else in the body do you have these lesions. So that's number 1. And number 2, this is a very wide differential. So I think, getting tissue is appropriate, even before going to kyphoplasty. So I think that your questions are spot on.
Great, thank you. So moving on, we have some labs coming back that are revealing a monoclonal protein of 4.2 grams per deciliter. Reductions in IgA and IgM, a free light chain elevation of 12, a kappa lambda ratio of 28. There's pretty mild anemia, hemoglobin only 14. Creatinine probably within normal limits for this patient, calcium 8.9, albumin 3.3, a beta-2 microglobulin of 4.3, and an LDH of 265. So Dr. Forsberg, is this the relevant information that you would want to see? And is there anything else that should be here from a diagnostic or prognostic perspective?
Well, this is sort of the most important lab work. I think this is the first part, in addition to, whatever leads people in the door with their initial suspicion of myeloma, whether that's imaging results or lab work, or even a biopsy, something that, a pathological indication initially. I think this, the lab work from, these lab results do include the variables that would be incorporated into that ISS and revised ISS. But, in terms of, so it gives you a good sense for maybe some of the things that are happening or are not. We talked about the CRAB defining criteria with myeloma, and it's always reassuring to see a patient who's not dealing with hypercalcemia or clear injury to their kidneys at time of diagnosis. But in addition to those lab variables that would help us to make the ISS and part of our ISS, we would certainly want to combine this with bone marrow information, cytogenetics, both karyotype and FISH, as well as any other potential pathological or disease-specific indicators of disease aggressiveness.
And so is routine urine testing still performed is that something that you do, or is that sort of gone by the wayside with respect to staging?
It's a great question. I think it's one of the things that can be pretty confusing, especially for people who don't treat myeloma quite as frequently. So urine is still an important part of our toolbox. We still routinely, at least I still, sort of routinely check 24-hour urines at diagnosis. Getting a sense for how much Bence-Jones proteinuria there may be gives you a sense for how at risk the patient might be for kidney injury. So getting a sense for what their degree of proteinuria might be. Beyond that, in certain patients, the urine 24-hour urine screening remains an important part of our response assessment. That's particularly important in patients who may be participating in clinical trials or other areas where we need to grade in a very by-the-book manner based on International Myeloma Working Group criteria. In real practice, the truth is that oftentimes we'll use the serum free light chain ratio as a pretty good surrogate for what may be happening in the urine. So instead of necessarily monitoring 24-hour urines every cycle like we would on patients in clinical trials, we may use it a little bit less frequently to sort of correspond with what we see in the serum with the serum free light chains, as well as when we're assessing depth of response in a more formalized way, possibly around transplant or when they've reached a maximum depth of response. So it is an important tool, but maybe one that the use has evolved somewhat as validation for serum free light chains as a very useful correlate for what we see in the urine has emerged.
Great, thank you for that. That's helpful. So as you suggested, this patient did have a bone marrow biopsy. It was hypercellular with 60% cellularity, atypical kappa light chain restricted plasma cells in clusters and sheaths, accounting for 30% of the total cellularity. I won't read through the karyotype. I think at a glance you can tell that this is of significant prognostic importance and unfortunately of poor prognostic relevance here. And then you see the specific FISH testing done. So Dr. Nuka, can I just ask you, I mean, when you look at the cytogenetics and then the FISH, what, besides the fact that this takes 4 lines on this PowerPoint slide, anything specifically stand out to you that is of greater concern, or any particular opportunities from a therapeutic perspective that come to light from looking at this patient's cytogenetics?
Sure. So as you clearly mentioned, like the karyotype, when it crosses more than 2 lines, I call it a complex karyotype irrespective of what it looks like. So this is a patient who has a complex karyotype, but what is more important to me is how many normal chromosomes this patient is exhibiting. So on the metaphase cytogenetics, you specifically are relying on the proliferative ability of these cells to grow, and it does not happen most of these times. So what happens is, if it's a proliferative neoplasm, you're seeing them to grow, and it only happens, you get a metaphase cytogenetic positivity only in 20 to 30% of the cases. So that was the sole reason why we use the FISH to look for the specific probes, to look for the usual chromosomes that you can see in multiple myeloma. The advantage is you have a higher sensitivity. The disadvantage is you only get what you're looking for. You don't choose a specific probe, and you're not, even though it is really existing in there, you're not finding it. So that was the difference between the cytogenetic metaphase cytogenetics and the FISH results. If you look in the karyotype of these, there are at least, if you take the percentage, there are at least more than 20% or close to 20% of the cells that are exhibiting this abnormal karyotype, which is really relevant in looking at this. If you have less than 5%, if it is one cell, we don't even know whether it's real or not. So the second aspect is when you look in the FISH. So the reason why we look for these genetic markers or the FISH abnormalities positive for 1q21, monosomy 13, or IGH FGFR3 rearrangements is mainly to risk stratify, are these patients exhibiting some of these known translocations that tend to have a poor prognosis. So I'll tackle the monosomy 13 first, which is seen in almost half of the patients, so not considered a high-risk feature. So we put that on the back burner. Then go to IGH FGFR3 rearrangement. This is a translocation 414 that we commonly talk about. Used to be a very high-risk feature in the past before we had the proteasome inhibitors in place. But after we had the proteasome inhibitors, these tend to respond very well to the bortezomib, carfilzomib, or ixazomib, the 3 proteasome inhibitors that are approved. And these have shown to have a better, these patients were shown to have a better prognosis than what we had in the past, but still not to the point where you see them on par with the standard risk patients. Now, tackling the 1q21 gain, this is an evolving field at this time. All depends on how many copies. Like we had shown from our huge data set that patients with 1q21 with more than 3 copies almost behave like a high-risk disease, like a deletion 17p. So, but in others, like who specifically have an amplification of 1q or have an extra copy, that potentially may not be as high risk as you normally would expect them to be. So that's a summary of what you look at the cytogenetics and the FISH specifically for this patient.
That's great. Thank you for taking us through that. That's really helpful. So this patient then has a PET scan, the majority of which the CT lesions are PET avid. There's also extensive lymphadenopathy within the thoracic inlet, the mediastinum, and the hyla. And in fact, an FNA of the left supraclavicular lymph node does show some rare plasmacytoid cells and some multinucleate giant cells. So Dr. Forsberg, can you tell us how common is it to have lymphomatous involvement? I guess first, would you say that this lymph node report that we're getting here is diagnostic of that? And if so, or even if not, how often do you see this?
I guess I would consider this not definitively diagnostic. You know, I think it's I guess somewhat suspicious, and since you do have plasmacytoid cells, you know, but if there is a quantity, in limiting the pathologist's comfort in sort of making a more definitive attribution, then I think I would also kind of hedge, in terms of feeling completely assured. So extramedullary disease involvement of myeloma is a fairly rare circumstance in the new diagnosis setting. The percentage of patients who have extramedullary disease at diagnosis is in the 10% or less range, whereas it does become more and more common as patients progress through subsequent lines of therapy. So, as patients are exposed to sequential therapeutic exposures and myeloma becomes more genetically diverse, it does more commonly gain the ability to live outside of the bone marrow niche, where it's often sort of confined to at the time of initial diagnosis. So the rate of extramedullary involvement, or things like plasma cell leukemia, whether that's involvement of lymph nodes or of spleen, liver, CNS, it can be sort of broad. It has, the natural history of myeloma has changed as our therapeutic armamentarium has expanded so dramatically, but it is a relatively uncommon scenario at diagnosis, and one that we would think is associated with a higher risk circumstance for the patient.
Great, thank you. So, the main question that we want to get at, and Dr. Nuka, maybe I can ask you to start with this, is, how would you treat such a patient? This is a 65-year-old, relatively healthy, newly diagnosed patient with these, several potentially high-risk features.
Absolutely. This is one of my peeves. Like, as I have to take you back to my story as a fellow, we found these exact same patients in the clinics when I was working with my mentors, and looked at what their treatment algorithm is. So all we're going is going into the patient's room and saying, hey, you have all these high-risk features, yet we do exactly the same treatment as we did for the previous patient, that stage 1 patient. So why do we, when we know that these patients tend to relapse pretty quickly, the relapse-free duration is very short, why do we treat them the same way as the other patient who don't relapse? So that led to a lot of discussion, and we, as a group, we decided we'll treat them differently. So how do we treat them differently? So it's not difficult to gain a response in these patients. You get the same 3-drug regimen, get them for a transplant, and you get a response. But the difficulty is to maintain that response. So what can we do to maintain that response? So we brought in the 3 drugs that we used in the upfront setting into this space, and we used the 3 drugs with RVD as maintenance for 3 years. So 93 of the patients were alive at the 3-year mark, and the PFS, median PFS, was greater than 40 months, which was unheard of at that time. And with the 45 patients data that we published in 2013, so there was a huge change in our thought process, which led us to initiate more of these trials with post-transplant intense maintenance approaches. So for this patient, clearly fitting all the criteria, who needs a proteasome inhibitor, possibly a 3-drug maintenance post-transplant is what my suggestion would be.
That's great. And Dr. Dr. Schuster, can you please comment on your opinion there?
Yes. I think that's some great questions about the FDG PET. First of all, FDG is a non-specific radiotracer. So sometimes, we will see patients with definitive cancer, but yet they have superimposed inflammation, sarcoid, et cetera. So number one, I think it is worthwhile to pick up the phone or go down and review the PET with your radiologist or nuclear medicine physician. Maybe that node wasn't the hottest one, and maybe there's a better target. And then to turn this around, I'm going to ask my colleagues here, okay, let's say that supraclavicular node is suspicious and it's pretty hot, similar to the other myeloma lesions. Would there be any utility in having a surgeon go in and getting more tissue, or is this kind of enough based on the FNA?
That's a great question. Dr. Forsberg, what do you think? I mean, would it change management to know more definitively whether that lymph node or another lymph node was involved? And how would you manage this case, I guess?
Yeah, I think in this case, I probably would think that you doing a more invasive biopsy to gain more tissue for a more definitive diagnosis would potentially be unlikely to change treatment, sort of our treatment approach. We know enough about the patient being high risk based on other disease characteristics. As Dr. Nuka described, I also agree with treating patients with high risk disease somewhat differently, or at least having different targets with therapy, in those patients. And so I think that, getting a sense, and if it is a difference between assigning a patient as high risk or not high risk, then it may be more worthwhile to be more invasive in terms of chasing down a definitive diagnosis. But if you have other indicators that point towards aggressive disease, then maybe you can spare somebody a more invasive procedure. I think that, Dr. Nuka pointed to data that they've published about, sort of multi-drug maintenance, and, they've shown some of the really most robust data in terms of how maybe you can help to try to overcome some of the high-risk features of myeloma by using a more intensified approach, for a longer period of time. I think that, with patients with newly diagnosed disease, you're always making a few decisions kind of out of the gate. What's your induction combination going to be? Are you going to, take the patient to an autologous stem cell transplant upfront, or, is there a role for a transplant at a different point in time? And then after transplant, what's their likely maintenance approach? For these folks with high-risk disease, I think, one of the goals at this point, I think, that's emerging is to try to target what Dr. Nuka mentioned before as in MRD, as a therapeutic goal. So I think in high-risk patients, those are the ones where we may want to try most aggressively to target MRD negativity if MRD is a test that you're able to bring into the clinical space, because there is some data to show that patients who have high-risk disease who achieve MRD negativity have better outcomes than patients who fail to achieve those outcomes. Now, whether or not those are patients who are destined to do better and we just succeeded in getting them to a better looking place, but I do think there is enough evidence to point towards patients who achieve MRD doing better, that should be a real therapeutic goal in patients who are fit enough to go through intensive approaches. So I would usually think about starting this patient on either a triplet or even a quadruplet regimen, one that, now we have more and more data adding a CD38 targeting monoclonal antibody like daratumumab to a proteasome inhibitor, an immunomodulatory agent, and steroids. So I might think of even a 4-drug regimen to start, used to maximum response. And then I agree about the importance of autologous stem cell transplant. I think it's an important consideration in any eligible patient, but in high-risk patients in particular, where we want to try to maximize our stability of remission, I think it's an important part of things. And then I agree, I would favor in the post-transplant setting a multi-agent maintenance regimen, probably incorporating a PI and an IMiD, particularly given the T414, for a period of time. Maybe not indefinitely 3 drugs, but at least for a period of time until we make sure that their disease stays in a good remission.
Great. Thank you. Thank you all. So, I mean, for a case such as this, it sounds like there's consensus that while it may be the approach of many to treat this patient the same or similarly to other myeloma patients, the high-risk features do warrant a different approach, at least by our experts here. And that approach would involve likely a larger number of different therapeutic approaches in the upfront treatment setting, and then after a transplant in the maintenance setting to try to overcome these high-risk features. That's really great. Very helpful. Thanks, guys.